Hello, everybody. This is Bia for You for Them. Welcome to our monthly podcast where we have physician leaders who come and give their time and their effort and their advice to our community and tell them about the issues, health issues that are really important. And today we have Dr. Eric Brandt. Dr. Brandt is the Director of Preventive Cardiology at University of Michigan. He has a huge role in gender disparities, in healthcare disparities, especially at federal level, at state level, and even at local level. He's very active with American College of Cardiology as well. It is an honor to have you here today, Dr. Brand, and we look forward to hearing from you. If you would please start by telling us a little bit about what does high or abnormal lipid mean to you when it comes to a female versus a male?
Well, thank you for having me. It's my honor to join you today. When thinking about cholesterol and lipids, you know what lipids are in general is what we think about, like cholesterol and also triglycerides, which are fats in the blood. They tell us a lot about somebody's physiology, and in general, for both men and women, as we age, the numbers often do increase over time, and in both men and women. It's a highly recognized risk factor that over the long term, more exposure leads to higher risk for cardiovascular diseases. Um, what I like to think about is that, men tend to develop disease earlier than women, but it's often that management goes under-recognized more often in women. So we have to be very keen to make sure that we're thinking really comprehensively about individuals and focusing on women-specific risk factors and making sure we're not missing the people that we want to treat earlier. Even though in the broad population, women are less likely to develop disease at certain ages, we need to make sure that we focus on those women-specific factors to identify who are the best candidates for treatment. So it's really about thinking about finding the right people to treat and treating them at an early enough age that we can prevent things.
That's a beautiful way of putting it. And Eric, when you talk about gender disparity, I think under recognition happens at both the levels. A part of it is among our physicians as well, who don't specialize in lipid management. And also a part of it is among our patients and our community. And women will often come to you and say, you know what, I don't want to try this medicine because of perceived side effects. And what is your approach typically? And are there real side effects that they should be worried about?
Yeah, that's a great point, and it comes up very commonly in our clinical practice. For the medications that we use for prevention, which are often medicines for blood pressure, but also for cholesterol, there certainly are side effects that occur, and they're fairly common. Especially cholesterol management is one of the most common disorders in the population. So many people, and especially once you get to the age of 50 or 60, it starts to become in some groups the majority of people that are managed for these conditions. So it's not common to hear from other folks that your same age, that you're taking these types of medications, and side effects are common, particularly with the cholesterol lowering medications that we use. They can be common. What I like to impress upon folks, though, is that there are serious side effects, and there are less serious side effects that, when someone's taking medication, ideally, we don't want them to be noticing anything different. But if you're having side effects, such as muscle aching when you're taking a statin, it's important to talk to your provider about that, because it's important for us to know, because there are a lot of medications available now, and just because somebody doesn't tolerate one medication, all of the different medications that we have different properties that might make them more tolerable for one person or another, or maybe there was an interaction with another medication that made it more likely for you to have side effects. So it's important to recognize that if a side effect occurs, that you talk to your provider about it. We can try alternatives. Our toolbox for these things is getting larger, especially for cholesterol management. We're in an era of so many new therapies that we can almost always find something that works and that is tolerated without side effects.
I think that makes a lot of sense to make sure that patients are aware that there's a lot that can be chosen from and it has to be individualized. Any suggestions on blood tests in addition to routine lipid panel that helps tell our patients what is their likelihood of, say, having a heart attack or a stroke or having poor outcomes?
Yeah, I think there are two tests that come to mind. The one blood test that is becoming globally increasingly recognized as a risk factor that often goes unrecognized, but is something that is actually genetically inherited, and women tend to have slightly higher levels of, is a specific cholesterol called lipoprotein little a. And I think this is important to know about for two reasons. One is if your level is high, it might change how your provider thinks about your other risk factors and whether or not it's the right time to manage certain conditions like high cholesterol. But number two, we are as close as you can come to being on the cusp of new medications. And I think probably within the next year or so here, um, there haven't been ways to necessarily treat lipoprotein little a, but we are just about to be in an era where that may be possible. So that's one test. The second test that comes to mind is that, often we may not be ready to start taking medication for cholesterol lowering, or we might not feel like the tools our provider is using, or we as providers might not feel like we have a really great sense of somebody's risk for disease. So oftentimes integrating a coronary artery calcium score, which is a low radiation exposure type of CT scan or type of X-ray where we can see whether or not there's any plaque buildup in the heart arteries, that can really help give us more information and decide on when the right time is to start these treatments.
I think that's very well said, Dr. Brandt. Any take-home points that you think are really important for people to know about lipid and heart health in 2025?
So I think the take-home points here is that we're in a modern era where we have a lot of treatments available to us. So make sure you talk to your provider about that. Something I didn't get a chance to touch on, but I'll add, I think, as a take-home point is that a lot of what we do in our preventive clinic here is we focus on lifestyle, and particularly what we've been talking about today, cholesterol. You can make major changes to your cholesterol in relatively short periods by eating the right types of food. So I think working with your provider or a registered dietitian on the right types of foods so their cholesterol can be a treatment of itself. That's one. Two is that we do have some tools, like I mentioned, that can make more precision health decisions, like the lipoprotein little a or the coronary calcium score. And then lastly, particularly for individuals that are worried about their risk, I think having an open conversation with your provider, particularly if you're worried that there might be women-specific risk factors that are being overlooked, thinking about those things and with your provider, I think having direct conversations about that can kind of open up options that might have been overlooked.
Thank you, Dr. Brandt. We appreciate you making the time. Some really, really great pieces of advice for lipids in 2025, what we need to know. This is Dr. Eric Brandt from University of Michigan, the Director of Preventive Cardiology there. And if you have any more suggestions for other topics, please email us on viayourselfcontact@gmail.com. We will see you next month. Take care and be safe. Bye-bye. Thank you, Dr. Brandt.
Thank you.